Health Alert is brought to you by OU Physicians in Tulsa. Hello, welcome to Health Alert. I'm Pam Butler. Today we're going to talk about hospice care from the medical perspective, and joining me is Dr. Thomas Costner. You're the medical director of St. Francis Hospice. Welcome to the program.
Well, thank you, Pam, and thank you for having me today.
This is really an important subject, especially when we look at the aging of America kind of thing, and people are living longer, and so you think that at some point in time people may end up needing hospice care. What is hospice care and what is its philosophy?
Well, hospice care is focused on palliative medicine, and palliative medicine is the care of those with a life-threatening condition or life-limiting condition to help in their pain and suffering at that time in their life. Rather than focus on curing the disease process, we focus on alleviating the symptoms that come with that condition.
Okay, now when you talk about palliative care, where does that sort of figure in terms of the disease process? Is hospice then appropriate at the last 6 months, the last year, the last 2 years, or how do we look at that?
Well, not necessarily. Palliative medicine is the focus. The focus is on the alleviation of some of the symptoms of pain and suffering. Hospice is the overall entity of encompassing palliative care at the end of life. Typically, our patients have less than 6 months or less to live. That's their prognosis, and those are what we focus on. We aggressively treat the symptoms that might be associated with the disease process that's causing them pain and suffering.
Okay, so if a person thinks about the acute chronic kind of difference in medical conditions, of course acute is usually something that you probably could get over, but it could lead to chronic. So this is if they're saying I have a chronic health condition, it has deteriorated to the point where, like you said, life expectancy is terribly diminished, at least to that 6-month perspective for hospice care.
Right, that is correct.
Okay, now when we think about hospice then, age-wise, we would assume, therefore, they're all ages. You're talking about children all the way to the older or mature adult, as I would rather say, versus elderly. Right. Is that entire gamut? Exactly.
At St. Francis Hospice, we take care of children, we take care of middle-aged people, we take care of the elderly, all with the prognosis of less than 6 months to live, again, we treat those symptoms aggressively, not necessarily to cure the disease, but to palliate or resolve some of the symptoms associated with it.
Now, with St. Francis Hospice, and maybe some hospices in general, does the person have to come into a hospital institutional setting, or are they able to stay in their own home setting should they choose to do that in terms of the medical care they're going to receive?
Well, most research has shown time and time again that most patients would prefer experiencing the end of life in their home. So our goal is to treat the patient at home. If at all possible, we try to do that. We occasionally treat patients in nursing homes. Frequently, we also do hospice consults in the hospital. We bring people from home to the hospital if their symptoms aren't well managed at home. But typically, most of the time, fortunately, we can manage most of patients' end-of-life symptoms at home.
So is this an instance too then at home, because we don't hear of that much anymore, where we know that you have workers that can come out into the home, like social workers or nurses, etc., to administer that care, or the chaplain. However, the physician, will they actually come into the home to treat the patient there, or do they have to make the institutional or office visits should they need the actual intervention of the physician?
Actually, both. At St. Francis Hospice, they have given me the opportunity to actually make house calls, and I see all the initial admissions that we have in hospice. They also have the ability to go back into their physician's office and see the physician for any care that they might need, whether it be associated with the hospice condition or whether it be associated with some other illness that's unrelated to their hospice condition. So we kind of have a twofold approach in that regard. We also will go to the home if they need symptom management. Let's say a patient is not doing well, the nurse doesn't feel comfortable managing the patient can't get into the hospital or doesn't want to go back to the hospital or the physician's office. We can make a home visit to see the patient to helpfully manage their symptoms.
So with that, and that's really fascinating what you talked about in terms of with their own doctor, they may still be seeing their other doctor for other issues or conditions that they're going to need that kind of support with. So how does the hospice physician really coordinate, you know, case management really with their primary care doctor or their specialist? I mean, how do you really do that so you don't end up in duplicating some services or duplicating medications, things like that?
That's a very good question. And the way we do that, we have a team leader, the nurse that's out in the home, and the nurse will first always call the attending physician for most care needs. The attending physician will be available. If the attending physician is not comfortable with that condition or feels like the patient needs to be seen by the medical director, then they'll call me. I'll go out to the home and see the patient. I also, a nurse may come to me and say the symptoms aren't managed real well. What do you suggest? I will give the nurse, the team leader, the suggestion. They will call the attending physician and make sure that the attending physician is fine with whatever suggestion I have, or he may have another suggestion to treat the patient's symptoms. And we work as a team together, sort of with our team leader in between, so that we don't duplicate any services like that.
Okay, and that's really important to know that you have
and
that.
it's a neat relationship that we have with each other too. I really like that part of medicine.
Let me ask another quick question before I go to break here. In terms of being in the home, from the medical perspective, you have others in the home who want to participate in some kind of way, or maybe they have, in terms of their culture, their faith, an alternate type of healer that they would like to be incorporated in their care. How do you, as the hospice physician, work with individuals either that are family members or if they have healers or others as a part of their faith? How do you incorporate them?
Well, that's an interesting question because that has come up a couple of times. The way I do it, and I love this part of medicine, going into the homes. I was in primary care for 23 years and it was always office-based, and so being able to go out in the home and really see how the patient's living and how their family is living really helps. But what I like to do is have a meeting, and a lot of times I've had meetings with ministers with the patient's family, faith healers, any naturalist, any type of individual that the patient relies on for help in their care. You know, we have a philosophy in hospice. It's sort of 4 pillars of care, and we look at the patient from a physical standpoint. We look at the patient from an emotional standpoint. We look at the social needs of a patient, and then we of course incorporate the spiritual part. And if we can blend all of those facets into the care, then we feel like we're managing the patient much better.
Excellent. I'm going to take a really quick break and come back and pick up on one question I have about the healers and their role, and move into others. So you stay put.
Okay.
And you stay put. We'll be right back.